We sort of have a quorum, and it is 7:05, so I guess I'll get started. This morning, we're going to talk about vestibular schwannoma. Figured it was a pretty good high-yield topic for the OTE. Ask you a few little questions without, and try to just hit really high-yield things. Obviously, it's a big topic. The more I did looking into it, the bigger it seems. So we'll get right into it. I've got my notes on one screen and my talk on the other. Let's see, it's gonna, oh, there we go. All right, so our goals for today, we'll talk about the definition and anatomy of vestibular schwannoma, epidemiology, how patients present and how to diagnose, guidelines for treatment, different algorithms based on size, surgical approaches, and then a review and buzzwords. So obviously, since we have a lot to talk about, I'm not gonna go super in depth on a lot of things, but we can have more as the rest of the year goes on. So vestibular schwannoma is a benign tumor. It's well circumscribed, it's unencapsulated. It arises from the Schwann cells of the vestibular nerve. The thought is that there's a particular junctional zone of the nerve, and this actually reminded me a little bit of like those transitional zones where squamous cell carcinoma stuff kind of happens, things like that. Does anyone know the name of this junctional zone? I was shocked to see this in a review book. If this ever shows up on the boards, somebody send me $10. It is the Obsteiner-Redlich junctional zone. Write that one down. So heaven help us if you ever see it. But anyway, that's a zone where the Schwann cells and the neuroglial support cells meet. So the Schwann cells, as they develop, they progress towards the brainstem and they get slowed when they hit these cells. So the thought is if the the cell division pathways are impaired, so if there's a mutation that leads to the proliferation of the Schwann cells, that's the thought of why these vestibular schwannomas happen in the IAC. Again, most of these vestibular schwannomas start in the internal acoustic canal, and they can enlarge the porus and extend into the CPA. The image I have here is of, we're going to talk about imaging later, but you had that wonderful CPA talk with Mohammed. Does anyone know what kind of MRI this is?
Is it a T1 with contrast?
It is. Wonderful, Mohammed. Why do you know that, or how do you know that?
Because you could tell that the nasal mucosa is a little bit enlightened, and you could see a little bit of the CSF is dark, so it's T1.
Fabulous.
And then you have an enhancing lesion in the CPA.
Yeah. Thank you. Wonderful. Okay. This is a quick model of what a Schwann cell looks like. There's the enveloping cells of a neuron or neural body, and it just helps the conduction be more efficient. If you didn't remember what a Schwann cell is, this is like that classic picture where they kind of wrap around and let the chemical signal and conduction become more efficient because you don't lose as many of the as many of the chemicals don't leak as much out of the cell. So that's what Schwann cells are, if you remember that. Next, this is just a little bit of cerebropontine angle anatomy. So again, where it is in the name, it's where the cerebellum sits right next to the pons. I don't know if you can see my mouse here. So a lot of important structures come out of there. For example, some important cranial nerves. So you have cranial nerve 6, 7, 8, 5 is a little bit more superior in the pons, and then you even have some of the lower cranial nerves coming out, 9, 10, 11, and then one of these might be 12 in there. So just a reminder of why these things can be affected with the vestibular schwannoma. And again, in this picture, if they're developing in the IAC and they're either extending into the cerebellopontine angle or into the IAC and enlarging in this area. Some of the anatomy you'll see with some of the surgical approaches that we'll look at later. You'll need to know the relationship of this petrous ridge, the superior semicircular canal. And then another thing to remember is that the cochlea is anterior and the semicircular canals are posterior, and that comes into play for a couple things, like just the different landmarks when you're doing your surgical approach, and also for the different nerves when they're sitting in the IAC, which, speaking of, here's another Quizlet for you guys. This is kind of another classic picture you could see on the boards where the nerves are in the internal acoustic canal. So I don't know which one's first, but what is this thing? It's a vertical crest within the IAC.
Bill's bar.
Perfect. Bill's bar. Occasionally also known as the vertical crest by unimaginative anatomists. So there's the vertical crest and the transverse crest. What is our anterior superiormost structure?
Cranial nerve 7.
Perfect. And what's the inferior anterior structure?
Cochlear nerve.
Beautiful. And how do you remember that?
7 up, coke down.
Loving it. And what are our two posterior friends?
Vestibular nerves.
Wonderful. Superior and inferior. And actually, one interesting picture I got off the Dackler Atlas looks at how these nerves twist around as they come out of the brainstem. So this is important if you're doing a middle cranial fossa approach and you're starting to drill in here. One of the things they talk about is that it's relatively safe if you're thinking of the pons here, relatively safe to start drilling along the petrous ridge because your facial nerve is protected by cranial nerve 8. So when you're close to the actual porus acousticus, where the nerves come off the brainstem and enter the IAC, your vestibular cochlear nerve, again, cranial nerve 8, one nerve initially, the vestibular cochlear nerve is more, a little bit closer to you. Oh, yeah, actually, if this is superior and inferior, that's still a little bit the same. Good to remember, so the vestibular is on top, and then they all start to split as you get closer. So when they ask you that classic picture, that's actually much closer to the end organs where the superior and inferior vestibular nerves have split off, and then 7 and the cochlear part of 8 have sort of hit their area. I thought this picture was really cool. I liked it. Again, remembering that the cochlea is anterior and the semicircular canals are posterior. And then one more picture here of just this area and all these cranial nerves to get an appreciation of where they are. So when you're coming in and you're actually retracting the cerebellum, it gets you a better look at this cerebellopontine angle. Again, 7 and 8 going to the porus acousticus. Remember that the jugular bulb comes up, swooshes around, and then becomes a sigmoid sinus. 10, 11 are down here, 5 is up here. So that's why as this gets bigger and bigger and bigger, it can impinge on these structures. So here's a look of what a smaller vestibular schwannoma can look like. And I'll have another couple pictures of these later. And then it can get bigger and bigger and compress the brainstem. Good pictures all around. So epidemiology, everyone's favorite. Since they're slow growing tumors and they can be observed over time, particularly when they're small, the prevalence is larger than the incidence. Just to again talk about those two different words you might see. Incidence is new diagnoses of the disease, and like prevalence or new incidences of the disease, and prevalence is just how many have already been diagnosed that are being observed. Typically, people are diagnosed in their 40s to 60s, maybe even older, so it tends to be older people. If it's a younger person presenting with a vestibular schwannoma, what other diagnosis should you consider?
Neurofibromatosis, maybe?
Correct. Excellent, Mohammed. So which type? Ooh, secondary question.
Type 2.
Perfect. Do you happen to know how many of those patients, which percentage get bilateral vestibular schwannoma? It's pretty high.
50%.
90.
Close, Sam. 95% of these NF2 patients can develop bilateral vestibular schwannoma. So if they're younger, if it's like a 20-year-old presenting with a vestibular schwannoma, you have to screen for NF2. Some of the studies I'm going to go into, there's like a couple like little graphs that I thought were interesting. Dr. Carlson out of Mayo Clinic has done a lot of epidemiological studies out of Olmsted County, where Rochester, Minnesota is. Let's take a look at these. So this is what he was looking at, the incidence of sporadic vestibular schwannoma in the county over the last 50 years. So looking at how the incidence has actually risen over the last couple of decades. You can see kind of in both men and women, the numbers are going up. And you might think, oh, wait, I had one more before I get into my other topic about that. And this is by age. So incidence by age is, again, these older adults, 50s, 60s, 70s, are more likely to be diagnosed by it. And you might think that it might be a discovery thing, like you're getting more MRIs, they're being incidentally found. And it's true, like MRIs are letting us find vestibular schwannomas smaller, but unfortunately these lines aren't labeled, but these two lines, the more superior lines, the lines that are closer to the top of the screen, are the incidence of incidentally found vestibular schwannomas, but the bottom lines are just overall numbers of vestibular schwannomas. So this is kind of show that in about 2003, that line of incidentally found vestibular schwannomas has sort of flattened out, but the incidence is still rising. So Dr. Carlson's studies is sort of proposing that maybe there is actually a true epidemiological shift in increasing vestibular schwannoma happening. They don't really have a reason why, but just, disease incidences and trends tend to shift over time, sort of like we're seeing with the rise in HPV, head and neck cancer. Maybe the incidence of vestibular schwannoma is going up, just as otosclerosis is somewhat going down. Like we don't really see as much surgery for otosclerosis anymore, when they used to be doing like tons and tons and tons of them. But maybe we'll be seeing more surgery for vestibular schwannoma, which can be very exciting for all of us, especially me. Here's a prevalence look. So we looked at incidence, where the incidence itself might be rising, and the incidence in older adults is particularly high. Prevalence similarly looks a bit like the incidence graphs. Again, as they get diagnosed when they're older, these people that are older that we're monitoring these symptoms is pretty much the same. So kind of if a patient's asking you, oh, like, how common are these, doc? Like, what kind of numbers can you give them? So in all adults, you could say like about 1 in 2,000 adults will be diagnosed with a sporadic vestibular schwannoma. But if you're over 70 years old, it's actually 1 in 500, because the incidence and prevalence of being diagnosed with this as an adult is actually an older adult who's older than 70 is actually a lot higher. Those are my little bullet points for epidemiology. 1 in 2,000 will be diagnosed with sporadic vestibular schwannoma in their lifetimes. 1 in 500 over the age of 70 will be diagnosed with sporadic vestibular schwannoma. These days, they generally are diagnosed when they're smaller and less symptomatic, and that's largely because there's a higher suspicion of them when as someone presents with unilateral sensory neural hearing loss. Now we're all kind of triggered to be like, oh, we have to get an MRI. That could be a vestibular schwannoma. So luckily, like with that education, they are diagnosed when they're smaller, but there may also be a true epidemiological shift happening, which is always kind of interesting to think about. Shift over to etiology of these things. So in studies done in neurofibromatosis patients, have come up with the etiology of why these tumors happen, which I've already touched on a little bit. But if we have chromosome 22q12, which is the chromosome that gets wonky, goes wonky in NF2, what protein does that code for?
Merlin.
Brilliant, Merlin. That's cool. That's a cool name. Also known as schwannomin by other unimaginative people. So what Merlin, overexpression of Merlin, it's actin cytoskeleton mediated processes, which leads to that cell cycle progression, which you mentioned. So it leads to, so if Merlin is more of a tumor suppressor gene, if those get knocked out, then you have that overproliferation and you get that vestibular schwannoma. Vestibular schwannomas are usually sporadic, but mutations in that like particular chromosome, in that NF2 Merlin chromosome, are in 90% of even sporadic vestibular schwannomas. That's kind of interesting, something to remember. So how do patients present? What do you guys think? How would like this, maybe the smaller one on the left present?
Hearing loss.
Wonderful. So if the tumor is primarily in the IAC and it's on the vestibular nerve, so it can grow up and start compressing more of the cochlear nerve, you can start with tinnitus. That can be a very, very early symptom, just unilateral tinnitus. And the hearing loss can start early. It's more of a slowly progressive hearing loss. It doesn't tend to come and go. I think unless it can get to a particular size where it compresses more of the vessels. And then that's sort of a thought of why sudden sensory neural hearing loss can happen in these patients. And now my favorite question, the two questions. How many patients with sudden sensory neural hearing loss have a vestibular schwannoma?
I'm never going to get this
About
question
five.
right.
No.
5%.
5%. Okay. In our little thing, we have, so it's low again, like 1 to 5%, maybe. I don't know. So, but then the other side of things, how many patients with the vestibular schwannoma present with sudden sensory neural hearing loss?
Same. 5%.
10. It's a little higher. So it's like, we're trying to teach them like the flip thing so that when people like ask you that question and they're trying to trick you, you know. So you're much more likely to have, vestibular schwannoma and present with sudden sensory hearing loss than to have sensory neural hearing loss and present with have a vestibular schwannoma. So that's that. So what kind of vestibular symptoms do people tend to present with? Trick question coming at you guys.
All of them.
Yeah, so they can be. So since these things do slowly progress, the vestibular system can compensate fairly well. So they don't tend to present with like true like vertigo most of the time early on, but they can be like weirdly off balance. They just feel a little bit off. And then rarely, again, as they get bigger and bigger, so for example, on this side, when they start to compress on other nerves, vestibular schwannoma can rarely present with facial nerve paralysis. If they do, it's usually a sign that it's pretty big. Or if it's a small tumor that is presenting with facial nerve paralysis, you have to think more of a facial nerve schwannoma.
Or they're at the fundus. At the fundus of the internal auditory canal. The facial nerve is the most resistant nerve. You'll have your hearing loss and then vestibular symptoms first. And the other reason, too, you have to think about MRIs with contrast didn't appear until 1987. And the quality of MRIs have improved significantly since 1985.
All right, so some of the key points from the history. Typically early on, it's unilateral tinnitus leading to slowly progressive sensory neural hearing loss. I already talked about that a little bit. You can get imbalance. They can also get some oral fullness. And early diagnosis depends on a high index of suspicion. So what are some findings on physical exam you guys might expect?
Histelberger's sign.
Yay, Phil. Wonderful. So what is that?
It's like a numbness in the contralateral bowl.
Yeah, it's on the contralateral bowl and posterior wall of the EAC because of that compression on 7. And then overall, typically, it's a normal microscopic ear exam. Otherwise, what would you expect on your tuning fork test? Depending on the degree of hearing loss. Crickets. That's okay. I know you guys know. I'll just wait. Okay, so on your Weber, where does the sensory neural hearing loss lateralize?
Wow.
The same side.
Did everybody die?
Ellen, and
To the same side, Linnea.
A sensory neural hearing loss goes to the opposite side. Remember, conductive same side.
Oh, sorry.
Sensory neural opposite. Cows. No, that's not cows. But conductive is same. Sensory neural is opposite. And since it's a sensory neural loss, your Renees are going to be normal. So I got to start moving. Actually, it's 7:25. I have so much more to do. The cranial nerve exam, again, depends on the size of the tumor. Most of those should be normal in these patients that are presenting with smaller tumors. And then as far as the rest of your neuro exam goes, look for nystagmus. We've talked about Romberg, Fukuda. You could try those different things. Cerebellar test, do your finger to nose. There we go. And then additional tests you'd want, at least an audiogram and an MRI. I do have to start moving along. So this is a picture of a unilateral sensory neural hearing loss, particularly in the high frequencies. One thing to look at down at the bottom is the word recognition score. So one of the hallmarks of a retrocochlear lesion is that the word recognition score is out of proportion worse than you would expect. So the sound volume is appropriate, whereas in like a typical sensory neural hearing loss, if the sound is loud enough, their word recognition score should be pretty good. But in something like a vestibular schwannoma, their word recognition score would be worse than you'd expect. Other buzzwords they talk about on acoustic reflexes, now I'll stop asking you guys as many questions, is that you could have, so if you have your signal coming in from that side, it can be disrupted by the vestibular schwannoma. So your ipsilateral, so any reflexes based off of the sound coming in from that side will be off. So your ipsilateral and your contralateral coming in from, for example, a right vestibular schwannoma will be down, but sound coming in from the opposite side will be okay. So your like left contralateral and left ipsilateral reflex pattern should be intact. Another thing I talk about is stapedial reflex decay. So if you have a suprathreshold burst and you get that stapedial reflex, if you have decay of that reflexive stiffening of the TM to half amplitude within 5 seconds, that's also suggestive of retrocochlear pathology. So that reflex, if you keep doing it, it will kind of tire out as it goes on. Another thing they talk about is rollover. So rollover is kind of a buzzword you could see on the board exams. So they give a phonetically balanced word test. Typically, as they increase the intensity of the sound that they're giving you on that test, you should do better and better because you're hearing it better. But if discrimination on a test like that decreases as the presentation level increases, that's called rollover, which is a retrocochlear lesion. So like counterintuitively, the louder the sound is, the worse they do on that test. So that's rollover. Another thing to talk about would be the ABR. We haven't really gone over ABRs yet in our Monday night review. We've talked a little bit about the peaks. So if you guys remember that E. coli acronym for remembering which wave corresponds to which peak. So what an ABR is, it measures the electrical activity along the auditory pathway from cranial nerve 8 to the lateral lemniscus about, or even to the inferior colliculus. And each of those peaks corresponds with one of those structures. So again, wave 1 is going to be, if you do your E. coli, it's like the 8th nerve. Wave 2 is, well, the proximal part of the 8th nerve. Wave 2 is more the distal part of the 8th nerve. Wave 3 is going to be your cochlear nucleus. Wave 4 is your olivary complex, and wave 5 is your lateral lemniscus. And they look at the absolute latency of the peaks. So when those peaks happen based on when the stimulus is given, and also the interval between the peaks. So that makes sense. If there's any kind of delay along that pathway, all those peaks could be shifted. If there's a particular problem with one of those structures, the time between the different peaks can be longer. So ABR used to be more used for diagnosing vestibular schwannoma, and then MRIs got super good. It does have greater than like 90% sensitivity for diagnosis of vestibular schwannoma, so it's something definitely to talk about. The downside of the ABR is that they have to have no more than like a 70 decibel hearing loss. So just kind of throw that in more for historical purposes. Vestibular testing in vestibular schwannoma, not really necessary for diagnosis. It can be helpful if you're trying to figure out which nerve it is. The thought is if, what did I say? If you have a reduced vestibular response in the involved ear, that it's more of a superior vestibular nerve tumor, and that can help more for surgical approach. VEMP, they're still kind of looking at whether or not it's useful, but again, overall, you don't really need vestibular, you don't need vestibular testing to diagnose a vestibular schwannoma. Dance on through. I'm going to talk faster and faster. So gold standard for diagnosis of vestibular schwannoma, like Mohammed sort of already mentioned, is a contrast enhanced T1 MRI. You can get high-res T2, things like that. If you are getting imaging and you have a CPA tumor, I know we already kind of went over how different CPA tumors present in our MNR a couple weeks ago. But the most common CPA lesion is actually vestibular schwannoma, which is probably why they ask a lot of questions about it on the board exam. The next three most common are meningioma, primary cholesteatoma, and arachnoid cysts. And then less commonly in that area, you can get cochlear nerve schwannoma, facial nerve schwannoma, IAC lipomas, hemangiomas, and vascular loop compression. To get a look at some of the imaging. I showed kind of one of these earlier. It's a T1, which you can tell because the CSF is not lighting up. The globes are also dark. And you can see this is a right-sided lesion. It's iso-intense to brain. This is a T1 with contrast. Again, same thing. The globes are dark. The CSF is dark, but then the contrast shows us this nicely enhancing lesion. You can tell a meningioma versus a vestibular schwannoma because the meningioma would have more of that dural tail. Again, they bring that up on exams because the meningioma also lights up with contrast. And you can see this little part of the schwannoma that's going into the IAC. Two other modalities to talk about, the T2. Again, you can tell it's T2 because the globes are bright, CSF is bright. It's hypointense to CSF. And then there can be some cystic components of the vestibular schwannoma sometimes. So the cystic components of it can light up brightly. This one doesn't happen to have that as much, but I thought I'd mention it. This is a fast spin echo technique, which shows good contrast, but doesn't involve giving contrast to the patient. So one of the textbooks was mentioning this could be a good alternative because it's a little bit faster. And if patients can't have GAD for some reason, then a fast spin echo can show. It showed this like little IAC lesion in here. Is there a role for CT imaging? Again, it can show bony erosion, or if a patient really can't tolerate MRI or when MRI is contraindicated, it's an option. It's not great for tumors less than a centimeter. They describe this whole process of an air contrast CT scan that could show an intracanalicular tumor, which is where they get an LP. You like inject a little bit of air and they position the patient so that the air like rises and gets into that space. Which sounds like, I guess, a very uncomfortable thing for the patient, but hopefully overall they can get an MRI. So let's go more into treatment. So there's a lot of things to think about when you're deciding what treatment to do for a patient with a vestibular schwannoma. Their health, their symptoms, the presence or absence of hearing are all big, the size of the tumor. So a rough guideline, which I got from, again, one of Dr. Carlson's talks out of the Mayo Clinic, where if they're small, you can observe them. So again, 0 to 2 centimeters. You watch them over time, so you get an MRI. You have the MRI diagnosis. You get another one in about 6 months, and depending on what it's doing, you get repeat MRIs pretty much annually just to see what's happening. If it is growing, they'll have to be turfed into more of an active treatment category, which they described as stereotactic radiosurgery versus surgery. Stereotactic radiosurgery, again, more if they're more asymptomatic, if they have good hearing, if they're slow growing, older, or if they don't want surgery. Again, this seems to be like very surgeon-based versus institution-based, how quickly people go to surgery versus stereotactic radiosurgery. If they're bigger, between like 1.5 and 3 centimeters, again, you have that decision of stereotactic radiosurgery versus surgery. But if they're larger, like 3+ centimeters, pretty much going for surgery.
It depends on the pressure on the fourth ventricle. Depends on the pressure on the fourth ventricle.
Whether you do surgery or stereotactic radiosurgery.
Right.
Or,
yeah. You get brain swell.
Yeah. Here's kind of a fun little graph of treatment modality by year and size. So overall, again, this is a 0 to 2 centimeter category. A lot of these, 30–40% being observed, another little small chunk getting radiation, and then microsurgery. And then just to point out that as the tumors get bigger, you're doing more surgery type stuff. So for observation, average growth rate is typically 2 millimeters a year, but it can be much higher. So that's why you have this smaller percentage of patients where if they're growing rapidly, you have to make that decision. excuse me, you have to make that decision to go to surgery. And then so patients with salvageable hearing may lose hearing as the tumor grows, which could be a downside to observing some patients. So again, you get that MRI about 6 months after the initial and then annually. And one reason to observe could be if it's an only hearing ear with serviceable hearing, it's a reliable patient with a small tumor who will continue follow-up, or if they're elderly or medically infirm, that's another reason to observe. These are some of the numbers from, again, Dr. Carlson's talk. His point was that the standard thing is that you're going to observe for 5 years, and after 5 years, that tumor is not going to grow. That's sort of like a rule of thumb that's been around. His thought was like there are some tumors that continue to grow, so there may be a reason for extended observation. So his numbers that he had coming out of Mayo was that 50% of tumors were requiring treatment after 5 years of observation. 60% of those tumors were exhibiting linear growth after 5 years of obs, and that 70% were showing volumetric growth. So they were doing some MRI studies, calculating more of the volume of the MRI. So if you're watching the lesion in a particular dimension, like, oh, it grew like in the AP dimension, and that's what you're following, they also can grow volumetrically. So looking at that actually showed that those tumors were growing after that 5-year period. So it's just a reminder to keep watching. One of the things to look at if you're trying to predict what's going to happen to the hearing as these tumors are growing, it's the initial pure tone average word recognition score, and an early change in those things can predict time to development of non-serviceable hearing. So if they present with rapid changes in hearing, again, that's a sign that that tumor will probably continue to grow and probably continue to cause worsening hearing. Quick plug, talking about stereotactic radiosurgery, that you know what it is. Again, it's just use of multiple radiation beams on a single target. It's a principal alternative active treatment for vestibular schwannoma. The goal is long-term prevention of tumor growth, maintenance of neurological function, preventing new neurological deficits. Go to the next one. There are advantages and disadvantages. It's a decreased hospitalization time and quicker return to work. I know patients have sort of described it in, oh, they like walk in, they get their radiation, and then they're like kind of back to work. It's good for elderly or medically infirm patients. You avoid those risks of surgery, and it can also be used for salvage if you have surgery and then they develop a recurrence and they need radiation. The disadvantages, again, they get this and they still need to get kind of like yearly MRIs to make sure it's working. They can't have recurrence, then you have to do surgery anyway. You can get symptoms after getting radiosurgery because of post-radiation swelling. So there's still risk of facial nerve damage. There is risk of sudden hearing loss, and there is risk of radiation-induced hydrocephalus and radiation-induced malignancy. All things to talk about with the patients. 737, get into the fun part. So here, again, scope of this talk is largely to help you guys learn some buzzwords for the board exams, but our different surgical approaches, translabyrinthine, middle cranial fossa, retrosigmoid, and then a combined approach, which would be several more of those modalities if it's a bigger tumor, affectionately known as TRANSLAB, MCF, and retrosig. Very fun. I like this picture out of the Jackler Atlas that shows why you may want to consider getting some of those ancillary tests to figure out which nerve this is coming from, because it can push its other nerves that are in the IAC towards different walls. So if this is, again, like, which direction's going on in here? Kind of losing it. So if your schwannoma is coming from the inferior vestibular nerve, it can push the facial nerve and the superior vestibular nerve directly towards where you're coming from. If you're doing your middle cranial fossa approach, something to be aware of, whereas the superior vestibular nerve tends to push all those things away. So part of your approach is going to be, if you know which nerve it's coming from, great. Tumor location and size, an important degree of hearing loss is a big one in picking which modality you're going to use. Like Dr. Diaz-Ordaz was mentioning, the facial nerve is a pretty hardy nerve, and it can get splayed a little bit ridiculously based on the size of these tumors. So as the tumor grows and compresses on this nerve, all the kind of like little axons inside can get really spread out. So you can get these like very fine gossamer webs of the facial nerve, and the facial nerve is working perfectly fine, like a little jerk, but you got to like kind of tease the tumor out among all these webs. That's that. So let's talk about these different things. So the TRANSLAB approach. is for patients without useful hearing. I'll get to some of the pictures later, but you're drilling through the semicircular canals to get to the IAC. It's useful for tumors pretty much of all sizes. It's the best one for protecting the facial nerve. It gives the widest exposure of the facial nerve because you'll find the facial nerve before you get to the IAC. And it provides excellent exposure to the CPA. It doesn't require retraction of the brain, so avoids retraction of the cerebellar and temporal lobes. So those are kind of those things on the board exams you can talk about. Again, if the patient does not have useful hearing, or there's a low chance of being able to preserve the hearing because the tumor is so large, think TRANSLAB, and again, protection of that facial nerve. Middle cranial fossa approach, again, if you're coming in through a craniotomy and gently retracting the temporal lobe up to get into the IAC. So middle cranial fossa and retroseg are the two approaches you think about if you're trying to preserve hearing. Middle cranial fossa is better for more lateral tumors when you're trying to preserve hearing. It's for smaller tumors restricted to the IAC, it's good. So if they're 1 to 1.5 centimeters, it's good for access to the fundus while preserving the otic capsule. And it can also be used if the vestibular schwannoma extends into the CPA with an extended approach. However, this is one where the facial nerve is slightly more at risk because you get more into the IAC before you get to the facial nerve and know where it is. And again, that facial nerve can be really splayed over the surface of the tumor. So that's something to think about with MCF. For retrosig, also affectionately known as a suboccipital approach by neurosurgeons, this is the traditional approach taken by neurosurgery, where you're doing a cranie. Again, there will be more pictures later, and you actually do have to retract the cerebellum out of the way to get into this area. It's a better exposure of the CPA than the middle cranial fossa approach. It aids hearing preservation for more medial tumors, but because to see all of that area, you'd have to actually like drill out the otic capsule, which you're not going to do. There could be more of a blind spot, so you might not clear all of the tumor. This one, because there's also like a slightly higher risk of CSF leak. It's the most likely to have headache as a side effect of the surgery. It's another thing that are sometimes in review books. Combined approaches for very large ones, for very large CPA tumors, more than 4 centimeters that have transverse intracranial compartments, if hearing preservation is not an option, or if you have a really big tumor with brainstem decompression, that's when you do a combined approach. So getting into the end of this thing, I've got a bunch of pictures to just point out some of the landmarks for our different approaches. So if I were a real jerk, I could ask you which ear this is, but I think that ship has sailed. Here we have a left ear, sort of our mastoid approach. We have Tegman with our middle cranial fossa, our ear canal. This is the digastric ridge. Again, the structure it's pointing out is the facial nerve, which, as we know, loops inferior and parallels the lateral semicircular canal. Perpendicular to the lateral semicircular canal is your posterior semicircular canal. The superior semicircular canal is not in view yet. Here's your incus, which has a nice little green star on it, your sigmoid sinus. So as you're developing these structures, so you drill out between the facial nerve and the sigmoid to expose your jugular bulb. Again, we know, like as we saw from a previous picture, that jugular bulb comes up as you're getting deeper and deeper. You're looking for your inferior border of the IAC and your superior border of the IAC, which will be, so again, inferior boundary is the jugular bulb, the cochlear aqueduct. This is going to be your inferior boundary of your internal acoustic canal. Your superior boundary is going to be the superior semicircular canal ampulla, which is going to be our most superior and lateral aspects of the IAC. The labyrinthine segment of the facial nerve is immediately anterior to that superior semicircular canal ampulla. So as you're getting deeper and deeper into here, you're drilling out this part inferiorly and this part superiorly, as we'll see in our next picture. This is, again, a little bit more zoomed in. Again, here's your facial nerve, your incus, your lateral semicircular canal, your posterior semicircular canal. You're starting to see the superior one. And as you drill out these beautiful semicircular canals, this is that superior semicircular canal ampulla, which is your superior limit of your IAC. I called this Mike's dot. I meant to look up which Mike that is, and I should probably know, but Mike's dot is that semicircular canal ampulla that you can see. So now this is an image of this. So these semicircular canals are completely drilled out. This is the vestibule. This is that semicircular canal ampulla. And you're starting to drill this out. And as this gets deeper and deeper, you start to see the shape of this internal acoustic canal. So again, this is just a reminder that your facial nerve is here, it's pretty much safe. And then as it makes its turn more superiorly by that superior semicircular canal ampulla and turns back into the IAC, that's where to be aware of your facial nerve. But you know where it is, so you can protect it through this approach. And then you start drilling in and around. Again, facial nerve is kind of up here, it loops around and comes back this way. And you get to the IAC coming through the mastoid and finding it that way. It's a lot of drilling. It's really fun to do in the lab sometime when you guys get that opportunity, just to like drill and drill and drill and drill and finally like reach this area. So you can see why that does not preserve hearing, because you're just cranking right on through the semicircular canals. This is the middle cranial fossa approach pictures. Let me go back one. So this is the one that's like kind of a little screwy. It's really hard to understand this until you've seen it, until you've drilled it in the lab. I wrote these in with my iPad. So this is going to be weird because it's upside down somewhat. So if you're at the head of the patient's bed, so superior is towards you, this is a left ear because anterior is this way, posterior is this way, and inferior is this way. This is where you really have to remember those things of like, okay, I know the cochlea and the facial nerve are more anterior structures, more posterior structures are going to be our lateral semicircular canal, and that's going to tie into as you're going down finding these things. There's your EAC, your zygomatic process, your middle fossa dura, again, anterior, posterior. As we start going down and raising the brain, the brain off of the bone, you start to see things. And one of the first landmarks you're going to see is the arcuate eminence. The arcuate eminence roughly marks the position of the superior semicircular canal, although that relationship can be a little bit inconsistent. Again, the superior semicircular canal tends to be perpendicular to the petrous ridge. The other big landmarks you're looking for is the middle meningeal artery, which is going to be is the anterior limit of your dissection. So again, you're kind of creeping in from lateral to medial. You're raising from posterior to anterior. And why that is because, again, your important anterior structures, the greater superficial petrosal nerve, is going to be more anterior. So to avoid damaging that, you're raising from posterior to anterior, looking for that, because that can be dehiscent in 16% of patients. That's another like Bordy type thing. And GSPN can be dehiscent in about 16% of patients. Remember that. And again, if this anatomy is very foreign, do not worry. It is weird stuff. So here's your arcuate eminence. Again, marks out superior semicircular canal. As you're moving posterior to anterior, you're getting into your greater superficial petrosal nerve. And your middle meningeal artery here is the anterior limit of your dissection. So then the other couple of little numbers to know for this area, make sure I have my number here. The superior semicircular canal makes about a 45 to 60 degree angle with the IAC. So that's kind of that other number. So if your arcuate eminence, which is roughly where the superior semicircular canal is, 45 to 60 degrees from that is going to be your IAC. So that's why you can start drilling in this area. Relatively safe place to drill is on that petrous ridge, which we talked about why that is because of where the facial nerve is in relation to the IAC. You remember it like twists and the facial nerve is farther away from you along the petrous ridge. So you kind of like just drill these areas down until you start to define the IAC. So here's that arcuate eminence, GSPN, that's your cochlea, and then there's your IAC kind of tucked into there. That's kind of a lot, but then like those buzzwords to remember from your MCF approach are, I guess, kind of like 4 or 5-fold. One, just to reiterate, you avoid injury to the GSPN by raising from posterior to anterior. GSPN is dehiscent in 16% of patients. The arcuate eminence marks the superior semicircular canal, and the superior semicircular canal makes about a 45 to 60 degree angle from the IAC. So that's, you have this, and that's sort of like where you drill to find it. Good. No one's panicking yet, I hope. Retro sig landmarks. This is the part where I sort of was like, meh. Just things to remember. So, oh, I didn't put an initial orienting picture. I apologize, that's my bad. So you're making a 4x4 centimeter cranie, and you're lifting up the dura. So this is your dural flap, there's your cerebellum. You retract the cerebellum, and you can see just, the IAC. It seemed like actually a pretty easy approach to finding the IAC. I was like, oh, you get in here and it's right there. But again, the risks that you have with this, you're retracting the cerebellum. There's the risk of CSF leak. So I don't know. I definitely and obviously started losing steam when I got to this part of the talk, because I know the middle cranial fossa approach is so overwhelming. So retroseg, pretty much an easy thing, and maybe I'll get into it more on MNR. All right, that's all the anatomy stuff. We're doing pretty well on time. So just to throw out a few more buzzwords for you guys for pathology, I'll show you maybe like a big pink slide, but the key buzzwords are Antony A and Antony B for vestibular schwannoma. Antony A is more of the compact cellular with elongated spindle cells, whirling palisading nuclei in rows, which are called I think my thing auto-corrected it, but it's like Verona K's bodies. Vestibular schwannomas tend to be mostly Antony A, and then the Antony B, if you can tell, the difference on here has more space in it. It's loose, less cellular, more spongy looking. So again, Antony A is going to be elongated spindle shell, whorls, palisading nuclei. Antony B is going to have more of this like space in it. Again, most vestibular schwannomas are type A, and as the tumor grows, you can have like more areas in necrosis and things like that. But overall, I kind of remember those two. Okay, now for the fun part. Questions. People want to unmute. We're going to go through all the high yield stuff that I was trying to hit you over the head with. Are you guys ready, residents? It's going to be fun.
I want to ask a question first, though.
Sure, absolutely.
How about cochlear implants post-acoustic normal treatment with gamma knife? Or hearing, or cochlear nerve preservation? Did you read anything on that?
I did not. I know I've been reading that it's definitely becoming more popular to use it after even like a TRANSLAB approach. People are implanting them, right?
Yeah, well, as long as it's a cochlear nerve, yeah.
Yeah. Okay.
So I've done a labyrinthectomy and cochlear for Meniere's, and it worked very well. But I just saw a patient with residual low frequency hearing loss and had a gamma knife about 10 years ago and wants a cochlear implant because her son was implanted with the cochlear implant a few months ago, done very well. So her 10-year-old son's encouraging her mother to get a cochlear implant. And I read the same thing, that they seem to be doing well.
Mm-hmm.
But I wanted you to give me some guidance. Oh,
I'll have to read more.
The middle cranial fossa approach, most patients are very whiny after that surgery. I don't know why, but it's been published as well. Usually my follow-up MRIs are without gadolinium because there's talk about gadolinium staying in the brain for the rest of your life. And all you're doing with follow-up MRIs is just measurements, so you already know the diagnosis.
I have a question for you guys. Does gamma knife change how, and if you need subsequent surgery, does it change how the surgery goes, or?
You expect more scarring, so it's harder to preserve the nerve. But I've done a couple, and they actually have done well. And I've done obviously without, and they hadn't done so well, with the facial nerve. They can be very, very, it's all you see is scar tissue. So, I mean, the idea too is to remove part of the tumor and then leave the rest behind for the gamma knife so you can preserve the nerve. The other thing is, sorry to tell this, Leanne, but the number of acoustic normal surgery has dropped considerably here in this town because we use the gamma knife a lot, and I have seen very few failures. So.
Yeah, I was saying it's like it seems to be very institutionally based.
Right.
Like, I think
right.
It's like some people and some people do like way more MCF versus retrosig or TRANSLAB. It just totally depends on the culture of a place. And but I was primarily using the Glasscock-Shambaugh book, and it was saying, there's aren't randomized controlled trials of which one's better, so everyone can kind of do what they want.
So is that Mike Stott Glasscock? Mike Glasscock?
That makes a lot of sense. And I still have that book and I'm giving it back to you. I haven't forgotten. I haven't forgotten. It has your name in it. I just love it. I'll give it back to you. Don't worry.
No, that's fine. That's fine.
Okay, guys, let's do this thing. So, this isn't actually a question, but just to point out, because we talked about this at one of our other reviews, that what the nervus intermedius is. So that's that branch of the facial nerve, which has everything but motor. So we talked about that. So the facial nerve comes off the brainstem with the motor, and the nervus intermedius is carrying the taste, secretory, and sensory fibers of the facial nerve. In the CPA and IAC, it's different, but then it is part of the facial nerve once it exits at the mental, it autocorrected that too. The meatal foramen, that's not supposed to be mental foramen. And then geniculate ganglion contains the cell bodies of taste carried by the chorda. So what fibers are carried by the GSPN?
Salivation and tearing.
Pimpari. This one doesn't dovetail off the other questions at all. I just threw that in there.
Yeah, like preganglionic parasympathetic. Is that what you're? Did you already mention that?
You got it. Well done. The preganglionic parasympathetic fibers are on the GSPN, and there's some afferent special sensory taste as well, I suppose. Where am I going next? Here we go. Okay, so what percentage of temporal bone specimens demonstrate dehiscence of the geniculate ganglion? I hope to God you were listening.
16%.
16%. Perfect. Love it. So what is rollover?
I can't hear you. You're
What
talking
is rollover on an audiogram?
The more you talk, the less I understand.
Dr. Diaz-Ortiz, these aren't for you. They're for the resident. But he's not wrong.
You know what? As a comment to that, nobody does those hearing tests anymore, right?
I know,
And
but they still
ABR
test us on it.
ABR all gone because, MRI is the way to go. No doubt, it is what it is. I think the hard part is also when do you get an MRI when it really doesn't meet the criteria, I mean, I saw a young man once just with ear pain, and that was it, and had ear pain for a long time with a normal exam. Turned out to have an acoustic neuroma.
That's crazy.
So, I mean,
wow.
So you try not to overtest, but the reality, you get to a point where I don't think you have to do something just to make sure.
Like that index of suspicion.
Yeah.
Yeah.
Remember, you're the last stop. I don't care what anybody says. It used to be the third most common cause for lawsuits, right?
Mm-hmm. All right, residents, or anyone else really. What is the stapedial reflex pattern seen with a right-sided retrocochlear pathology?
So you'd have absent reflexes when presented to the right, and then bilateral reflexes when presented to the left.
Yes, well done, Sam. This was contentious. Which percentage of patients with sudden sensory neural hearing loss have a vestibular schwannoma? You can do it, Sam. I mean, just explain the question of why
1%.
we get MRIs. Yes, very good. You got it. You got it.
I did.
Yay. And then what percentage of patients with vestibular schwannoma have a sudden sensory neural hearing loss?
10%.
Perfect. What protein does NF2 gene code for?
Merlin.
Yay. Even Charlie's going to know that one by the end. So what are indications for TRANSLAB? Just like a quick, 1 centimeter. I mean, not 1 centimeter. Wow. One sentence summary.
Loss of hearing.
I like it. Loss of hearing or tumors where the chance of hearing preservation is low. There's one. How about retrosig?
It's really big.
Oh, hearing preservation too.
Yeah, hearing preservation and or it's more medially based. So if you think again as retrosig and MCF as the two hearing preservation surgeries, retrosig is if the tumor is more medial and middle cranial fossa if the tumor is more lateral, just because of how you can get to it.
Quick question on that. For middle cranial fossa, I feel like we get questions about retracting the cerebellum. Is it pretty, do they have a lot of side effects from that?
For retrosig,
Or,
Is-
yeah, sorry,
yeah.
retrosig.
yep. They can have, that's the one where they get more like headache. Like that's kind of the big
Headache.
question they ask
Headache, I think, is more from all that
for all of
muscle
them.
section off the bone. You know, it's the pressure on the cerebellum, and if you see it after hours of operating, they get pretty beat up, and it's really more imbalance. Fine motor,
Wow.
it's all cerebellar.
Okay.
Perfect. And then, yeah, here are the buzzer questions. Which approach is more associated with headache? Most associated. This is from like the Mayo Clinic review book thing.
That's what you just said.
Yes, retrosig. And which approach puts the facial nerve most at risk?
Middle. Awesome.
Perfect. Dr. Diaz-Ordaz is ready to pass the board.
Only the neurotology, maybe. You know, in temporal lobe retraction, worry about there. Seizures. That's why they have to do it very slowly. Same thing with cerebellum. Do it very slow and keep it moist. That's why they cover it with wet sponges.
And this is one I didn't actually mention. So more for retrosig, which superficial landmark approximates the transverse and sigmoid sinus?
So,
I feel like we don't really get into suture lines as much as neurosurgeons do, and maybe we should. I'll give like a neurosurgery oriented approach, but it's the asterion, which I figured Phil's like, yes, that's right. That's the junction of the lambdoid, parietomastoid, and occipitomastoid suture lines. So that landmark, like the junction of those suture lines, approximates where the transverse and sigmoid sinus kind of meet.
and the difference between a retrosigmoid and a suboccipital approach is the proximity to the sigmoid. Because neurosurgeons will, to avoid the sigmoid, will go back a lot further to avoid it. And as you use a neurotologist, what you'll do is you'll identify the sigmoid, decompress it, because the closer they can get closer to where they want to be, which makes it easier.
I think this is the last one. So what is that zone along the eighth nerve where vestibular schwannomas are hypothesized to arise from?
Funny little name.
Somebody who's very famous and is very proud of this, probably.
I thought proper names were out.
I don't remember those fancy names.
It's like Obschleider, Reich, something.
Very nice. Obersteiner Rudlick.
Okay.
Gesundheit. Phil, what is Hestelberger-Stein? We talked about. Anyway, and then how are CPA tumors radiographically different from vestibular? Oh, meningiomas. How are meningiomas different from vestibular schwannoma on MRI?
The dural tail.
Well, okay. That's my talk.